This is the Berman Method podcast featuring Dr. Jake Berman and physician assistant Jenny Berman. We are here to treat problems and not symptoms. Disclaimer, this podcast is for entertainment purposes only and not to treat anyone or to give medical advice. If you are interested in any information that we are giving and would like to use this for yourself, we recommend that you contact your primary care physician or reach out to us and ask us questions about yourself specifically. Enjoy.
And we're back. The Berman Method podcast. Dr. Jake Berman here with my lovely wife,
Jenny
Berman, physician assistant certified. What's up?
Oh, yeah. We're back.
We are back. Hope you had a great week. Today, we've got some exciting, controversial topics for you today. Well, one topic, knee pain. Knee pain, it's a very controversial topic, especially in my office, not so much in Jenny's office, but definitely in my office. So we are going to debunk a lot of myths out there about knee pain.
Dun-dun-dun.
Dun, 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 dun. Cool. So you want to get started?
Yeah, I'm ready. So I think the most common question or comment that we get, or you get, I should say, is my doctor told me my knee is bone on bone, so I have to have a knee replacement. So, I don't know what you can do for me, probably nothing, because I have to have a knee replacement.
That is a very common one. We'll have those people call the office and say, I don't know I'm calling you. My friend told me that I have to give you a try. My doctor told me that I'm bone on bone. I got the Xrays to prove that I am bone on bone. I have to have a knee replacement. There's nothing else that can be done. Myth number one.
Debunked.
Well, not debunked yet. Let me explain why it's debunked. This actually goes back to when I was treating in Jacksonville, working for Aaron Robles up there at Innovative Therapy Solutions, amazing manual therapist. So if any of you guys are ever up in the Jacksonville area and you want to get tuned up, I highly recommend you seeking him out. It's got magic hands. Anyways, I was working at his clinic one day. Well, I was working there every day, but I was working on one of my patients who just had a total knee replacement, and it was a week out. And anybody that has had a total knee replacement knows that that first week is usually the worst week, excruciating, a lot of pain. And this patient said, I'm really not looking forward to having the other knee done. So the purpose for this example, let's say that they just had their right knee replaced. And they're talking about dreading having their left knee replaced. And I said, why do you have to have the other one replaced? And they said, well, on Xray, the left knee was worse than the right knee, but the right knee hurt more. So that's why we replaced the right knee first. And this was not the first time that I had heard these words. I've heard them multiple times from different patients over the years. But when this particular patient said it out loud that time, it really made me think that the left knee in this particular patient, the left knee was worse on Xray, completely bone on bone. There was no cartilage left. Yet it was the right knee that was so excruciating that they decided to have the right knee replaced first. So that got me thinking, can we say that bone on bone causes pain?
Well, I mean, you would think it would, but obviously not if he wasn't really having much left knee pain and it was more bone on bone than the right.
That's the point, is a lot of people tell me that this knee's bad. It's bone on bone. It hurts. It cracks. It does all this stuff. Been having injections over the years. Nothing's going to save it. Got to have it replaced. However, my rebuttal is this case that I'm talking about here, and it wasn't the only one. This has happened multiple times over the years where this patient's knee, his left knee that didn't hurt at all, was exponentially worse on Xray, straight up bone on bone, but there was no pain in there.
And they still wanted to replace it?
Well, they said he was going to have to get it replaced.
Okay. I know that's not the point, but I'm just checking.
Yeah. So that's what really started to make me question this whole when do you really need a knee replacement theory or process that the doctors put you through? Because essentially you go to the orthopedic surgeon when you have knee pain, and the first thing that they do is they take x-rays and they say, yeah, you've got some cartilage loss there, or you're bone on bone here. You're going to need a knee replacement. Try to put it off as long as you can. Hopefully they say that anyways. But what I'm finding here is over the years, these patients are complaining about worse knee pain in the knees that look better on x-ray.
So what do you think is causing their pain? If it's not bone on bone, do we have a short answer, or that's a whole nother episode?
No, we can make it a short answer. Super duper long story short, the pain response, the thing that is sending the pain signal to your brain, is not the bone on bone. It's the soft tissue structures around the knee joint. So the muscles, tendons, ligaments, those things that are getting overstressed is what's sending the pain signal to your brain saying that your knee hurts. It's not the bone on bone that is sending the pain signal back. So I know that there could be tons of people that are going to argue that that's not accurate if you look at it from a physiological standpoint and pain receptors and the sensitivity of bone. However, this is what I'm arguing. I'm arguing it from a functional standpoint, that the cause of knee pain is not necessarily the bone on bone or the bone grinding on itself. However, as much as it's the soft tissues being stressed around the bone on bone.
And why are the soft tissues stressed?
Great question. Because the number one cause of knee pain that I've found over the years is
a weak butt.
Weak ass syndrome. Yes. Believe it or not, the glutes are one of the biggest knee stabilizers in the whole entire body. It's not the quad. So, a lot of people who have knee pain, they go to the cookie cutter physical therapist and they get these exercises to strengthen their quads. So they're doing leg extensions or straight leg raises or short arc quads or all these other quadricep focused exercises. However, the number one cause of knee pain that I found over the years is weak ass syndrome, the glutes not firing. And again, super duper long story short, the reason why that is because we want every single joint in your body to be supported completely around the entire joint. So 360 degrees around the joint, you want support around to support that joint. If you look at the knee, if you're just strengthening the quads, that's supporting the front of the knee. But there's still a whole nother 180 degrees behind that needs support too. And that's where the glutes come in. The glutes are going to give you support from the back of the knee, the posterior aspect of it. So to bring this back full circle to somebody who has bone on bone and knee pain, I can tell you pretty much within 20 minutes, 30 minutes max on the first visit, whether or not you need a knee replacement. And the way we know that is when you get on our table, we push down on your knee. Can we get your knee completely flat into overpressure, pain-free? Usually when you first get up on the table and we push down on it, it hurts. There's a pain response. That makes sense. So then we go through and we do our magical manual therapy stuff and do our soft tissue skills and do some neuromuscular re-education, get some muscles firing again. And then we reassess that at the end of the session, 15, 20, 30 minutes in, and the pain response magically goes away and we can push the knee completely flat into hyperextension. When we can do that, go ahead.
I was going to say because you have Jesus hands.
Healed. Oliver, if you ever listen to this, that's shout out to you. No, so when we can push the knee completely flat without a pain response, that's when I can say, okay, I'm 99.9% certain that you do not need a knee replacement. And the reason why I say 99.9% certain and not 100% certain is because I have had one patient over the years where I did get her knee completely flat into hyperextension, pain-free, and we never could get the pain response to go away because she was a hypermobile patient, meaning that all of her joints moved a lot, which requires a ton of strengthening. And it was just one of those things where it just took too much work to get it done. So she ultimately had a knee replacement. But for the 99.9% of everybody else, if we can get that knee completely flat into hyperextension, pain-free, then the chances of you avoiding a knee replacement are through the roof.
So what does that knee extension have to do with the bone on bone?
Great question. When you can get the knee completely straight using muscles, it actually unloads the knee joint. However, when the knee has a slight bend in it, and again, we're talking about just a couple of degrees, couple of degrees significantly increases the compressive forces on the knee joint itself, because when it's slightly bent, your glutes are not firing. Everybody can do this at home right now. It's super easy. Just stand up and bend your knees slightly when you're standing there and try to squeeze your butt as hard as you can. Okay, I'm sure everybody's doing it right now. Now, try to hyperextend your knees, push your knees back as far as you possibly can, and now squeeze your butt as hard as you can. You better be able to feel your butt squeezing much harder with your knees straight or hyperextended than you can when your knees are bent.
So most of the people that are having knee pain walking around are not getting their knee into full extension.
Correct.
And that's what's causing the pain, not necessarily the bone on bone.
Correct. Because when the knee has a slight bend in it, that increases the compressive forces on the knee joint, and that requires so much more effort from the surrounding soft tissue structures, and that essentially leads to being overworked and underpaid. So all those soft tissue structures get inflamed, and that's what causes the pain response.
Can you argue that the bone on bone is a result of the knee not being straight and the increased forces over the knee?
Again, this is my theory, but I'm saying 100%. And the reason why I'm saying 100% is because if it was inevitable for the knee joint to degenerate and it was inevitable for you to not have bone on bone, how can you explain the people who are 80, 90, and even 100 with their original parts? There's something different about them, and I will not just chalk it up to, oh, good genetics.
So speaking of genetics, my mom has really bad knees, so I'm destined to have bad knees and have to have a knee replacement. She had both of her knees replaced when she was 60, so I'm going to have mine replaced. And this is not my real mom. I'm just hypothetically speaking.
Yes, this is a very common excuse that I hear over the years is, my mom gave me bad knees. My dad gave me a bad back. It's genetic. It's inevitable. Not necessarily. There is a congenital aspect, and I have seen it where you were born with your skeleton was slightly off.
Or low cartilage, yeah.
Yeah, I've seen this before. However, again, I'm going to go out and say it on record. Less than 1% of the population that I see can blame it on congenital issues. So to go back to, well, how can we explain it? My mom had bad knees, so I have bad knees. I really think that the number one reason why this occurs is because you tend to mirror your parents' posture.
Mm-hmm.
Yeah.
Posture, activity levels.
Posture, activity level, but really just posture. Just think about it. You're under the same roof as your parents, usually for 18 years. So you just start to mirror their posture. And it's not necessarily just the upper body posture, it's their mannerisms. It's really everything about the way they move that you, not consciously, but subconsciously start to mirror. So I know I'm going to have some people arguing with me on that one too. However, again, I'm telling you, we're breaking all the rules here. One of my favorite things that my business coach tells us is when the majority and the popular people go left, go right. So we're going against the grain, baby.
So I guess that makes sense, though, because if you have the same types of posture, you're going to have the same types of breakdown and the same type of muscle weakness. Okay, I get it. Okay, so I'm moving on. What about like the people who don't really have much pain, but they hear a lot of popping and grinding and gross noises in their knees, so the doctor tells them, you're going to have it replaced?
Again, I disagree. I really do.
What is that popping, grinding?
The technical word is called Crepitus.
Mm-hmm.
And there's been multiple studies that are looking at Crepitus, and the outcome, quickly summarized, is it's not a good thing, it's not a bad thing, it just is. So again, some people might argue with me on that one. However, that's the research that I've been exposed to, where Crepitus, it's not a good thing, it's not a bad thing, it is what it is.
But Crepitus, to clarify, is not the bone-on-bone grinding.
No.
Yeah.
No, Crepitus is usually the ligaments and tendons kind of just popping around in the knee joint. Remember, the knee is a hinge joint, so it's really meant to bend and extend. Those are its two main focuses. There's a slight rotation that occurs medial-lateral. However, its main functions is to bend and extend. And when you don't have that joint 100% efficient from below and above, meaning your foot and ankle and your hip, if those things are not 100% on the same page, then there's going to be some torque that occurs at the knee joint. And that's going to place some increased stresses on some of those soft tissue joints. And that's what can cause them popping over bony structures. But again, it's not necessarily a good thing, a bad thing. It just is what it is.
So what about if I have a torn meniscus? Do I have to have surgery on that?
I love this one. Absolutely love this one. And the short answer, we're going to do two answers. We're going to do a short answer and a long answer.
Ooh.
The short answer is, if you have a torn meniscus and your knee does not get locked, meaning it doesn't get stuck in a position, excruciating, by the way, when it happens, so I've heard, if your knee does not get locked, then you do not need to have meniscus surgery. Now, for the long answer, they've done multiple studies where they are looking at people who have had meniscus surgery. It's called debridement, where they go in there and they just clean it out. They get rid of the rip or tear or the floating body that's in there. And they look at people who do conservative treatment, meaning they go through physical therapy. And they look at them at 6 months, 12 months, and two years, and they rate their quality of life. And the people who had the conservative treatment, meaning going to physical therapy, they did not have the scalpel, report higher outcomes and less pain at 2 years post-op or post-diagnosis than the people who did have meniscus surgery. So again, if your knee is not locking, it's not getting stuck in place, please don't get surgery. Just get in there and get some strengthening going on. Strengthen the glutes, get that thing into full terminal knee extension, pain-free. Same thing that we started this conversation with earlier. And if you can do that and really get it stronger, you can avoid knee surgery. Their studies have shown it.
Well, yeah, and I'm going to jump in on my 2 cents here, coming from an orthopedic background as well. So the meniscus is a C-shaped cartilage, right? So if you go in and it's partially torn, but not creating a locking or, getting stuck, when they go in, they actually trim the cartilage out. Well, we've been talking this whole time that the cartilage is important to prevent this bone on bone that you're feeling. So if they go in and cut the cartilage out, you're already having less cartilage, versus if we do the physical therapy to strengthen the butt muscles, the leg muscles, then we're keeping that cartilage. And even though it's torn a little bit, we're still, one, it's still there, and two, we're strengthening the surrounding structures, which is going to create a longer term outcome, positive outcome. Is that right?
That's very right. And the thing that we have to, since we're already talking about this, we have to talk about, was it a traumatic tear or a non-traumatic tear? Did your meniscus tear just over the years from hard use, quote unquote hard use? I have people tell me all the time, I really abused my body in my 20s, 30s, 40s. I ran a lot, I played football, played a lot of tennis, whatever the quote unquote excuse is. That is called a non-traumatic or insidious meniscal tear. When that's the case, you better go through conservative treatment. Don't cut that thing off unless it locks. If your knee locks, then go in there and get rid of that floating body because it's floating around the knee joint. Get it out of there and then strengthen everything. But if it's a traumatic tear, meaning that you slipped and it just ripped, then that could be different. And again, it comes down to, is it locking or not?
And where the tear is. That matters too. But this is getting pretty deep.
Yeah, let's just stay superficial here.
So, and from a personal experience, I had a knee surgery when I was 13, I believe. And they actually did a meniscal repair, which is very uncommon. It's common in a young athlete because they want you to keep the cartilage, especially if you're as young as I was. But that was a super long recovery. I mean, I was on crutches for weeks, whereas normally with a meniscal debridement, and they just shave it out, you're walking out of the OR, or at least the next day you're walking. So there is a difference too between a repair and debridement. Debridement.
Yeah, let's touch on that because this is one of the things that frustrates me to all ends when somebody goes and does decide to have the meniscus debridement. They walk in there, they have the surgery, and they literally walk out of there, and the surgeon does not tell them that they have to go to physical therapy. Mm-hmm. This drives me absolutely insane. They say, just take it easy for a couple of days, and you should be pretty good in a couple of weeks. Just get back to your normal daily life. Drives me insane, especially if it was an insidious tear in the first place, meaning it just happened over the years. You've got to go to physical therapy after you have a scalpel inside of you. I don't care if it's orthoscopic or they actually cut you open. When you have a scalpel in your body, you've got to go to physical therapy afterwards because you've got to retrain your brain how to use those muscles again. Your brain literally forgets how to use the muscles because the anatomy has been changed. Just remember that. When the scalpel goes in, the anatomy is changing. When the anatomy is changing, you've got to retrain your brain how to use the quote unquote new anatomy.
Well, and, even going more into this, when there's a traumatic event to the knee, the quadricep itself just completely gives up. It quits working, and the hamstrings actually tighten up to try to protect the knee since the quadricep's not working. So we have to go back and, as Jake is saying, retrain the quadricep, retrain the glutes how to fire. The other thing is, if you've had this tear for years, the knee isn't working the way it should be for years. And so now you're going in, doing the surgery, they're taking it out, you're going back to your normal activity and nothing is better. The pain's not better. Well, the pain's not better because you haven't reactivated the glutes, reactivated the quadriceps, even though you said the quads aren't that important. But they are a little.
It's not that I'm saying that they're not that important. I'm saying that they're overemphasized or...
Right. I could agree with that.
People are just focusing 90 or 100% on the quads versus let's do 50-50. Let's do 50% on the front of the knee, 50% on the back of the knee. The front of the knee is the quads, the back of the knee is the glutes.
Right. We could agree with that. But the point is you have to get the glutes activating to get the quads activating. You got to get both of these activating to take the knee pain away. So if you're one of those that have had your meniscus done or you've had your ACL done 15 years ago and you're still having knee pain, it's probably not an anatomical problem that's happening now. It's more of a physiological problem where you just haven't retrained your muscles, reactivated the muscles.
Right. And I know that when I ask people, especially when I'm talking to them over the phone, about a knee problem, does your knee go completely straight? 9 times out of 10, they say, yes, it goes completely straight. However, when you look at it going completely straight, it's different from me standing on top of you and pushing it completely straight. Those are two very different things. If you can't have somebody push it completely straight into hyperextension, pain-free, you're never going to be out of pain. Write that down. That's probably the most important thing that we're saying on this whole entire episode is if you can't have somebody push your knee into hyperextension, even after a knee replacement, we haven't even talked about knee replacements. We're already at almost 25 minutes, so I don't think we should get into it. But after you have a knee replacement, let's just quickly, briefly go through it. The first thing that you have to do after a knee replacement is get pain-free hyperextension. If you can't get pain-free hyperextension, you have 0% chance to be out of pain. I frequently have people that have had a knee replacement who get sent to the cookie cutter physical therapist that is owned by the surgeon. And the first thing, or the whole entire treatment program is them doing self-guided things, essentially. They go on the bike, they go and they do the leg press, the leg extensions, but nobody ever helped them get full hyperextension. Yeah, they might get to neutral, but I'm talking about hyperextension. You've got to have at least 5, if not 10 degrees of hyperextension, even with a knee replacement, or you will never be out of pain. So that's probably the most important thing we talked about in this episode is those last few minutes.
Mm-hmm. And we'll talk again more about knee replacements maybe on another week. But yeah, it really, everything that we've talked about today has come down to you need to be able to over straighten your knee. That's what hyperextension means. Get it over straight by passive, right? Someone else doing it for you to prevent pain after a knee replacement, before a knee replacement, after a meniscal surgery, when you have quote unquote bone on bone, any of those things.
And what's the number one cause of knee pain? Which weakness?
The buttocks, the booty.
Yes, the glutes. Number one cause of knee pain is glute weakness that I've found over the years, especially with my demographic. 50, 60 plus, glute weakness is the number one cause of knee pain.
Done.
Anything else?
I think that's it. I mean, still is a lot we could talk about on the knee, but we will maybe pick up on another one.
Yeah, a different episode. We'll come back to knee replacements and go into more detail because I'm sure we're going to get some questions or...
Yeah, if you have any questions about your own knee pain, ask us so we can answer those on the next knee pain podcast.
Perfect. Very cool. So again, I hope you guys enjoyed it. I hope that this made you question some things that you've been told over the years. I hope that if you're one of those people that does have the Xray saying that you got bone on bone, that you're really starting to question things. See if you can get that knee into hyperextension. See if your butt's firing. There's all sorts of tips and tricks that you can try on our YouTube page. So let's figure it out. Let's try to avoid the scalpel. Original parts are the best parts.
Perfect. I like that. That should be a new one.
Original parts are the best parts?
Yeah, a new slogan for us. Treat problems, not symptoms. Original parts are the best parts.
Very nice. All right. That's all for now. So I hope everybody has a great day and we'll see y'all or hear y'all next week.
Ciao for now. Thank you for subscribing on your social media and podcast platforms to the Berman Method. Dr. Jake Berman with Berman Physical Therapy and Jenny Berman, Physician Assistant with Berman Health and Wellness. You can find more information on our website, www.bermanpt.com for physical therapy, bermanpt.com/wellness for the health and wellness. You can also find us on social media, Facebook, Instagram, and on your podcast platform. So be sure to follow us, like us, subscribe to us. And if you would like any further information, definitely visit our website and reach out to us. You may also find our free reports on the websites as well, where you can download this free information for yourself. Have a great day.